All right, let's skip the fluff and jump right into the high-yield Step 2 CK triage pathways for reproductive health and male GU. We're talking abnormal PAPs, postmenopausal bleeding, ovarian masses, prepubertal presentations, and contraception choices. Let's go. Section 1. The cervical screening timeline. Okay, let's look at this timeline. If your patient is under 21, literally step away from the swab. Zero screening is indicated. Why? Because those young immune systems are absolutely phenomenal at clearing transient HPV infections. Now, once they hit 21 up to 29, the standard is cytology, just your basic pap smear every 3 years. But when they hit the big 3-0, the algorithm opens up. You can stick with cytology every 3 years or introduce HPV co-testing or primary HPV testing every 5 years. That 5-year gap is a huge win for patient compliance, but remember, you only unlock it at age 30.
So, when can you safely take a patient off the screening pathway? You can only hit the brakes at age 65 or post-hysterectomy if the cervix was completely removed. But wait, there's a catch. They have to have a pristine recent screening history. We're talking 3 consecutive negative PAPs or 2 consecutive negative co-tests and absolutely zero history of high-grade dysplasia. If they don't check all those boxes, you keep screening.
Now, here is the board examiner's favorite exception: a history of CIN 2 or 3. If you spot this in a vignette, the clock completely resets. You have to screen that patient for a full 20 years past the date of detection. So if a patient had CIN2 at age 55, she doesn't get to stop at 65. Nope, she's screening until she's 75. Don't let them trick you on the math.
Section 2. Managing CIN and abnormalities. When you get an abnormal result, your first diagnostic step is colposcopy with acetic acid to actually see the abnormal tissue. The acetic acid basically dehydrates the cells. Normal tissue stays pink, but those abnormal, rapidly dividing cells with dense nuclei, they turn stark white. We call those classic aceto-white changes, and they tell you exactly where to aim your biopsy forceps. Oh, and side note, colposcopy and biopsy are totally safe during pregnancy, so don't hesitate there.
So how does this play out in a management plan? If you have a non-pregnant patient diagnosed with CIN3, observation is totally off the table. Your next move is always an excisional procedure. Think LEEP or a cold knife conization. But your job isn't done yet. You have to follow up with a really strict surveillance algorithm, starting with HPV-based testing at 6 months. If that comes back negative, you can safely step them down to annual testing for the next 3 years.
Definitely keep this in your back pocket for your OB vignettes. Excisional procedures have real consequences. A cold knife conization significantly increases the risk for structural issues later on. We're talking cervical stenosis, which can lead to secondary dysmenorrhea or even infertility. And more dangerously, it compromises the structural integrity of the cervix itself, which sets the patient up for preterm birth, PPROM, and second trimester pregnancy loss. Always check the surgical history if you have a pregnant patient with cervical insufficiency.
Now, if the vignette describes a bright red, friable cervix with purulent discharge, triage that immediately as acute cervicitis and treat it empirically. Crucially for test day, active cervicitis or unexplained bleeding are absolute hard stops. No IUD placement allowed. And speaking of contraception triage, estrogen methods are completely out for patients with a history of thromboembolism, migraines with aura, or severe hypertension. What if they have breast cancer? The copper IUD is your go-to.
Section 3. Endometrial biopsy diagnostic logic. Whenever you see an older, obese patient presenting with postmenopausal bleeding, warning bells should be going off in your head. The main driver here is excess unopposed estrogen, which is often coming from the peripheral conversion of androgens in adipose tissue. If you grab a transvaginal ultrasound and see an endometrial stripe measuring over 4 millimeters, an endometrial biopsy is absolutely mandatory. You have to rule out malignancy.
But remember, it's not just postmenopausal women. Age 45 is your magic threshold. For anyone 45 or older, any abnormal uterine bleeding automatically buys an endometrial biopsy. No questions asked. But if they're under 45, you need an extra risk factor to justify it. You're looking for signs of prolonged unopposed estrogen, like obesity or chronic anovulation from PCOS, or maybe a strong genetic driver like Lynch syndrome. Once you have the biopsy, treatment hinges entirely on that pathology report. If it shows endometrial hyperplasia, you can actually often manage that medically with progestin therapy to counteract the estrogen, which is great, especially if the patient wants to preserve fertility. But if that biopsy reveals outright endometrial cancer, medical management is out the window. The definitive treatment there is a hysterectomy.
Section 4. Ovarian cancer and hereditary risk.
The brutal reality about ovarian cancer is that it usually presents really late. Patients will come in with super vague symptoms, bloating, early satiety, maybe some nonspecific pelvic discomfort, and by then, it's often already advanced. Because of this, identifying high-risk patients for hereditary cancer syndrome testing is your best and honestly your only real early defense. You've got to map out that family tree. So you need to know the high-risk red flags. If a patient's family history ticks any of these boxes, like early onset breast cancer, male breast cancer, Ashkenazi Jewish ancestry, or multiple relatives with Lynch syndrome-associated cancers like colon or endometrial, you have to offer testing for BRCA or Lynch mutations. If they test positive, they jump into a high surveillance protocol, transvaginal ultrasounds and CA-125 testing every 6 months starting at age 30. And eventually, you're looking at a risk-reducing bilateral salpingo-oophorectomy once they are done with childbearing. Now, do not fall for the examiner's favorite distractor here. If you have an average risk, totally asymptomatic woman sitting in your clinic, there is no screening indicated for ovarian cancer. No routine ultrasounds, no baseline CA-125 checks. The false positive rate is just way too high and the subsequent interventions are too morbid. Just stick to the algorithm. Section 5. Vulvar rules and prepubertal exams. Please lock this rule into your brain right now. If a prepubertal girl presents with vaginal bleeding or discharge, and it doesn't matter if you suspect trauma, a retained foreign body like toilet paper, an infection, or even a rare malignancy, you do not use a standard speculum. It's inappropriate and highly traumatic. If an internal exam is absolutely unavoidable, it's done under anesthesia using a vaginoscope or another appropriately sized instrument. Moving over to adult vulvar conditions, you've got to be able to differentiate intensely itchy lesions. Lichen sclerosus presents with severe pruritus and thin, white, wrinkled skin, often described as looking like cigarette paper. You diagnose it with a punch biopsy, and it requires high-potency topical steroids. On the flip side, if you have chronic vulvar pruritus paired with a persistent, non-healing plaque, an ulcer, or bleeding, you absolutely must biopsy to rule out vulvar squamous cell carcinoma. This is especially true in patients with a history of persistent HPV or even chronic lichen sclerosus. Section 6. Male UGI emergencies and oncology. Let's pivot and finish out with some high-yield male GU. First up, paraphimosis. This is a painful, swollen glands that happens after the foreskin is retracted and can't be pulled back over. This is a bona fide urologic emergency that requires immediate manual reduction. Next, cryptorchidism. If an undescended testis hasn't dropped by 6 months of age, they need an orchiopexy. This is crucial to preserve fertility and to allow you to monitor for malignancy later on. For GU oncology, always be on the lookout for a 15 to 35-year-old male presenting with a painless, firm testicular mass. Honestly, this is testicular cancer until proven otherwise. And whenever you do, never biopsy it. Instead, get an ultrasound. Check tumor markers like AFP and beta-HCG, get your staging imaging, and proceed straight to a radical orchiectomy. All right, let's do a rapid-fire recap to close out this explainer. No cervical screening under 21. Endometrial biopsy is a must for postmenopausal bleeding. Unexplained bleeding means absolutely no IUD. Emergency contraception is most effective with a copper IUD within 120 hours. Paraphimosis is a reduction emergency, and a painless testicular mass gets an orchiectomy, not a biopsy. Trust the algorithm tomorrow. When you read your next vignette, ask yourself, what is the very first branch point in my mental map? Keep crushing those practice questions, and we'll catch you in the next explainer.